We aren't just talking about the heart as a pump today.
No.
We aren't talking about valves and plumbing and blood pressure.
Yeah.
We are talking about the heart as an electrical generator.
That is a crucial distinction. When you go to the hospital and
Yeah.
they stick those sticky pads on your chest and print out that pink grid paper with the squiggly lines, the electrocardiogram or ECG,
Yes.
you are looking at a record of electricity, not movement, electricity.
Exactly. And I think for most people, myself included, those squiggly lines are just patterns.
Yeah.
You know,
Sure.
you look at it and go, okay, spiky line means heartbeat, flat line means trouble. It's like looking at Morse code without knowing the alphabet. You just know a short beep is different from a long beep.
Which is pattern recognition, and that is fine for a machine or maybe a first-year student.
Right.
But humans can do something better. We can understand the physics behind the pattern. We can understand why the line goes up or why it goes down.
And that is our mission today. We are doing a massive deep dive into Chapter 12, Electrocardiographic Interpretation of Cardiac Muscle and Coronary Blood Flow Abnormalities. Vectorial analysis.
It's a mouthful.
It is, but I love that subtitle, vectorial analysis. It sounds like we are navigating a submarine or piloting a spacecraft.
In a way, we are. We're navigating the electrical currents of the body in three-dimensional space. The goal of this material is to take us from "that line looks weird" to "I know exactly which milligram of heart muscle is failing because I can calculate the vector of the electricity."
So we're going to explain every single line of this method. We're going to visualize the arrows. By the end of this, I want you, our listeners, to be able to close your eyes and see the electricity sweeping across the heart.
It's worthy goal.
So buckle up. Let's start with the basics. Set the stage for us. What is a vector in this context?
In physics and in cardiology, a vector is just a tool to describe a force. Think of it as an arrow.
All right.
But it is a very specific arrow that tells you two things at once. First, the direction the arrow is pointing tells you the direction the electrical flow is moving.
Okay, direction. That's intuitive.
And second, the length of the arrow tells you the voltage, how strong that signal is.
Oh.
So a short arrow means a weak signal. A long arrow means a massive surge of electricity.
Okay. Direction and strength.
Oh.
Simple enough. But where is this electricity coming from? I mean, we aren't plugged into a wall socket.
It comes from the difference in charge across the cell membranes. And this is the fundamental rule we have to establish before we go any further. If we don't get this, nothing else makes sense. We need a zero reference.
Lay it on me.
In the heart, when a muscle cell is resting, waiting for its turn to beat, it is polarized.
Polarize.
That means the outside of the cell has a positive charge.
Resting equals positive. Got it.
When a muscle cell fires, when it contracts, it depolarizes, the chemistry flips, and the outside of the cell becomes negative.
So firing equals negative.
Precisely. Now, here is the rule of physics in a volume conductor like the human chest. Electrical current flows from the depolarized areas, the negative ones, to the polarized areas, the positive ones.
Okay, let me visualize this. The current flows from the active firing muscle
The negative areas.
toward the resting muscle that hasn't fired yet, the positive area.
Correct. It's chasing the positive charge. And our vector arrow. It always points in the direction of the current flow.
So the arrow points from the negative part of the heart toward the positive part.
You got it.
Okay, I have that mental image. Current flows to the positive. Now let's look at the heart itself. It's not just a blob. It has a shape, and the electricity travels a specific path.
It does. And the flow follows that architecture. When the heart beats, the spark starts at the top, in the atria, but the main power, the part that generates the big signals we see, comes from the ventricles, the bottom chambers.
Right, the big pumping chambers.
And the depolarization starts at the septum. That's the wall between the two chambers.
And it moves outward.
Yes. It moves from the inside lining of the heart, the endocardium, outward to the surface, the epicardium. But simultaneously, it sweeps from the top, the base of the heart, down to the bottom, to the apex.
So if I were to draw one big arrow representing the average heartbeat, combining all those little movements, it points from my right shoulder area down toward my left hip.
Exactly. That is the instantaneous mean vector. At any split second, if you added up all the tiny little currents flowing in millions of cells, you get one big resultant arrow pointing mostly down and to the left.
Down and to the left. That is our true north for this deep dive. If the arrow points there, things are generally okay.
Generally, yes. But down and left is a bit vague for a medical diagnosis. We need precision.
Right.
We need a map.
This brings us to the hexagonal reference system.
Exactly. This is where it gets good.
This is where we put a compass on the chest. Let's walk the listener through this. Because if you can visualize this clock face on your chest, everything else makes sense.
Absolutely. Imagine a giant circle drawn on the patient's chest facing you. The heart is the center of the clock.
Okay.
We define 0 degrees as horizontal, pointing straight to the patient's left arm.
Okay, so 3 o'clock on a standard clock face is 0 degrees.
Correct. Now, we use the standard leads of the ECG to mark the degrees. You know when they hook up the wires to your ankles and wrists?
Yeah, the limb leads.
Those form the triangle that gives us our angles. Lead eye records the voltage difference between the two arms. Its axis is exactly horizontal, so lead eye sits at 0 degrees.
Got it. Lead eye is the horizon.
Then we have lead 2. This connects the right arm to the left leg. The electricity flows down and left. On our circle, lead 2 is at plus 60 degrees.
So that's like 5 o'clock.
Roughly, yes. It's a good way to think about it.
Nice.
Then lead 3, which connects the left arm to the left leg, sits at plus 120 degrees. That's down at the bottom right.
Okay, so we're moving clockwise. 0, 60, 120.
Then we have the augmented leads. These are calculated leads. AVF stands for augmented vector foot. It looks straight down from the chin to the feet.
So straight down.
That's plus 90 degrees, straight vertical.
Okay.
AVL is augmented vector left. It looks at the left arm. That is at negative 30 degrees, so that's pointing up toward the left shoulder. And AVR, augmented vector right, looks at the right arm way over at plus 210 degrees, pointing up and to the right.
So we have this star pattern, or hexagon, slicing up the chest like a pie. You mentioned earlier that the normal heart vector points down and to the left. Where does that land in degrees?
The mean QRS vector for a normal heart is about plus 59 degrees.
Plus 59. That is incredibly close to lead 2, which you said is plus 60.
It is practically identical, which is why in a normal healthy person, if you look at the ECG strip, the squiggly line on lead 2 is usually the tallest and strongest.
Because the heart's natural electricity is pointing almost exactly parallel to that lead.
Exactly. The camera of lead 2 has a perfect head-on view of the train.
Okay, that is a perfect segue. We have our map, we have our arrow. Now we need to understand how the arrow turns into the squiggle on the paper. This is section 2, projecting vectors.
This is the physics of the squiggle. This is the part that blows people's minds when they finally get it. An ECG lead is just a voltmeter. It has a positive pole and a negative pole.
Like a battery tester.
Exactly. Now imagine the lead is a line across the chest, and imagine the heart's electrical vector is an arrow floating nearby. To know what the machine will record, you have to project the arrow onto the line.
Project. That sounds like geometry class. Can we simplify that?
Let's try. Think of it like a shadow. If you shine a light perpendicular to the lead, the vector casts a shadow on the lead's line. The length of that shadow is the voltage. Or, let's use an even better analogy. Think of the lid as a camera.
I like that. So lead eye is a camera sitting on the left side of the body looking across.
Right. And the electrical vector is a train. If the train is coming straight at the camera, it looks huge. It fills the frame.
So a big image.
A big positive signal. That is a full positive signal.
So train coming at me equals graph goes UP.
Exactly, a positive deflection. If the vector points toward the positive side of the lead, the graph goes UP. Now, if the train is driving away from the camera,
It gets smaller. The graph goes down in.
a negative deflection. And what if the train is passing perfectly sideways across the camera view, left to right, not getting closer or further?
Then the camera sees 0 forward movement. It's just a blur passing by.
Exactly. If the vector is perpendicular to the lead, the ECG records a flat line, 0 voltage. This is called isoelectric.
Okay, so let's apply this. You said the normal heart vector is plus 59 degrees. Lead eye is 0 degrees. They aren't perfectly aligned, but they are both pointing leftish.
Right. If you look at the geometry, and the source material has these great diagrams, figure 12-4 and 12-5, you see that a vector at 59 degrees projects a pretty decent amount onto the 0-degree line.
So it's not a perfect head-on shot, but it's coming towards the camera.
Exactly. So lead eye will show a positive spike. It sees the train coming, just at an angle.
But light too.
Since the vector is at 59 and lead 2 is at 60, they are almost twins. The projection is maximum. Lead 2 records a huge spike, the biggest of them all, usually.
But what about something like ADR? That lead points to the right shoulder, plus 210 degrees. The heart points to the left foot, plus 59 degrees. They're going in opposite directions.
Exactly. The vector points almost directly away from AVR. So AVR will record a deep negative deflection. The graph goes down.
The train is speeding away from that camera.
Right. If you see a positive spike in AVR, it means something is very wrong. The electricity is flowing backwards. Or the leads are on wrong.
So when we look at an ECG, We aren't just looking at random bumps. We're seeing the same electrical event from different angles.
Precisely. It's like taking 6 photos of the same car crash from 6 different street corners. By looking at all of them, you can reconstruct exactly what happened in 3D space.
Now let's get into the time lapse, because the heart doesn't just fire all at once, right? It's a wave. The vector changes millisecond by millisecond.
Yes.
The text breaks this down into steps, 0.01 seconds, 0.02 seconds. Let's walk through a single heartbeat in slow motion.
Let's do it. This is the genesis of the QRS complex, the big spike we see on the monitor. We start at time 0. The impulse has just left the AV node and hit the ventricles.
Step 1, 0.01 seconds, 1/100th of a second in.
The first thing to depolarize is the septum, the wall between the ventricles. But here is a nuance the text emphasizes. It happens specifically on the left side of the septum first.
Why left?
Because the left bundle branch, the wiring on that side, usually delivers the signal slightly faster. So the depolarization wave moves from the left side of the septum toward the right side.
So the vector points to the right for just a moment.
Correct. For a split second, the electrical arrow points to the right. Now think about our leads. Lead I and lead 2 are sitting on the left side of the body.
So the arrow is pointing away from them.
Exactly. Since the train is moving away, lead I and 2 record a tiny negative dip. This is called the Q wave. It's small, and it happens fast. It's the sound of the septum firing.
Okay, Q wave done. Next step, 0.02 seconds.
Now the signal spreads down to the apex, the very tip of the heart. The endocardium, the inside lining, is firing everywhere. The vector gets longer because more muscle is involved.
The more voltage.
More voltage. And it swings around to point essentially straight down and left, towards that plus 59-degree mark.
This is the main event.
This is the R wave. The vector points strongly toward lead I, 2, and 3. So all those pens on the chart shoot upward. This is the big spike.
Okay, so we are at the peak, 0.035 to 0.05 seconds. The wave is moving up the outer walls of the ventricles.
And here's a crucial detail. The left ventricle is much thicker than the right. It's the heavyweight champion.
Right.
It has to pump blood to the entire body, while the right side only pumps to the lungs.
So the left side has more muscle mass.
Much more. So as the signal travels through both walls, the left side generates way more voltage.
So the left side wins the tug of war.
Yes. The vector shifts or rotates slightly to the left because the left ventricle is dominating the signal. Lead 1 and lead 2 are still recording high positive voltage.
And finally, 0.06 seconds, the base of the heart.
The signal has reached the very top of the ventricles near the valves. This is the last part to fire. The vector is small now, and it might point slightly upward or to the right for a brief moment as it finishes. Then, silence.
The arrow disappears, the heart is fully depolarized.
And the pen returns to the 0 line. The QRS is over.
That is fascinating. It's a dance. Right, down left, hard left, done. And that dance creates the shape we see.
Exactly. It's not a single event, it's a film strip.
But wait, the heartbeat isn't over. The muscle has to reset. It has to recharge. This is repolarization. And the text calls this the T-wave paradox.
Yes. This is one of those things that confuses medical students for years. It's a classic exam question.
Okay, lay it out. When the heart fires or depolarizes, the outside becomes negative, the current flows, and the graph goes UP.
Correct.
When it recharges or repolarizes, the outside goes back to positive. The polarity flips back. So physically, you'd expect the graph to go down.
Logically, you would.
But the T wave, which represents recharging, is a bump UP. It looks just like the QRS, just smoother.
Why? It's a great question. If the wave of recharging followed the same path as the wave of firing, the T wave would indeed be negative. But it doesn't.
It goes backwards.
It goes backwards.
Yeah.
Think about the pressure. When the heart contracts, the pressure inside the ventricle is enormous. It is squeezing the blood out.
Right.
That high pressure squeezes the blood vessels and the tissue on the inside, lining the endocardium.
Okay, so the inside is under stress.
A lot of stress. Because of that stress and relative lack of blood flow during the squeeze, the inside lining takes longer to recover. The outside surface of the heart, the epicardium, isn't under as much pressure. It recovers first.
So the recharging starts on the outside and moves in the opposite direction.
Precisely. Repolarization travels from the outside surface toward the inside. This is the opposite direction of depolarization.
Okay, let me do the math here. Depolarization is a wave of negative charge moving left, giving a positive spike.
Yes.
Repolarization is a wave of positive charge returning, but it's moving.
Right. Well, think of it in terms of vectors.
Right.
A wave of negativity moving left creates a leftward vector. A wave of positivity or recharging moving right also creates a leftward vector.
Whoa, that feels Counterintuitive, a double negative.
Essentially, the physics works out that because the polarity is reversed and the direction is reversed, the vector arrow still points in the same general direction. It still points toward the apex.
So the T-wave vector points the same way as the QRS vector.
Yes. Which means on the graph, the T wave goes UP, just like the QRS. It's positive.
That is wild. It's like two wrongs making a right in physics.
It is nature finding a way to keep things aligned. Now, there is one other wave, the P wave.
The little bump before the big spike, that's the atria, the top chambers firing.
Right, and since the atria are at the top and fire downward, the P wave vector points generally down and left. So the P wave is also positive in the standard leads.
But wait, the atria have to repolarize too. Where is the atrial T wave?
It exists, but you almost never see it.
Why not?
Two reasons. One, the atrial muscle is thin, so the signal is small to begin with.
Okay.
Two, and this is the main reason, it happens at the exact same time the massive QRS complex is firing. The scream of the ventricles drowns out the whisper of the atria repolarizing. It gets buried in the QRS.
Poor atria. Always overshadowed.
Always. But it's there, hidden in the noise.
All right, so we have the normal heart. P wave, QRS, T wave. Vectors pointing generally plus 59 degrees. Now let's break the heart. Let's talk about when the arrow points the wrong way. Section 4, electrical axis deviation.
This is a huge part of clinical diagnosis. If that means vector, the average arrow swings too far left or too far right, it tells us something physically has changed in the chest.
Let's define normal first. The text says normal is anywhere from -20 to plus 100 degrees.
Correct. It's a pretty wide range. Anything in that cone is considered okay. But let's say the axis shifts to -15 or -30 degrees. That is left axis deviation. The arrow is pointing up toward the left shoulder.
Why would it do that?
It could be simple physics. The heart hangs in the chest, right?
Yeah.
If you exhale deeply, your diaphragm pushes up, the heart lies more horizontal.
Oh, interesting.
The vector shifts left. Or if a person is very obese, the abdominal fat pushes the diaphragm up. Same effect.
So short, stocky people might naturally have a leftward axis.
Often, yes.
Yeah.
Even pregnancy pushes the heart horizontal. But then there are the pathological causes, the bad stuff. The biggest one is left ventricular hypertrophy, LVH.
Hypertrophy means muscle growth, like a bodybuilder.
Exactly. Suppose you have high blood pressure, hypertension. Your left ventricle has to pump against that high pressure every second of every day. What happens? It gets buff. It gets thicker.
And more muscle means more electricity.
Yes. And it also means it takes longer to fire all that muscle. So the left side becomes a super strong electrical generator that stays on longer than the right side.
So in the tug of war between the right and left ventricles, the left side is now a giant.
It's the heavyweight. It pulls the entire average vector toward itself. The axis swings left. We see this in aortic stenosis too when the valve is tight. The left ventricle has to work harder.
Okay, so if you see left axis deviation, you're thinking fat, lying down, or a giant left ventricle from high blood pressure.
Correct. Now flip it. Right axis deviation. The arrow points to plus 120 or plus 170 degrees, pointing to the right hip.
Normal causes.
Tall, lanky people, their heart hangs straight down like a teardrop, so the axis is more vertical.
And pathological.
Right, ventricular hypertrophy. If the right side gets huge, maybe due to pulmonary valve stenosis or congenital defects like tetralogy of Fallot, the right side wins the tug of war. The vector swings right.
It makes sense. The vector follows the muscle mass.
It follows the mass, and it follows the time. And that brings us to the next section, bundle branch blocks.
Traffic jams in the heart. This is section 5. I love this concept. The heart has a highway system, right? The Purkinje fibers.
Yes. The Purkinje fibers are like a superhighway. They conduct electricity incredibly fast, about 4 meters per second, so the whole ventricle pumps at once.
A coordinated squeeze.
Yes. But what if one lane of that highway is blocked?
Then you have to take the side streets.
Exactly. You have to conduct the impulse through the muscle tissue itself. And muscle conduction is slow. It's like getting off the Autobahn and driving through a muddy field.
So what does that do to the graph?
It widens it. A normal QRS is sharp and skinny, 0.06 to 0.08 seconds. Snap, done. If you have a block, the QRS gets fat. It lasts longer than 0.12 seconds.
Okay, so wide QRS equals block. Now, how do we know if it's a left or right block?
We look at the vector again, and we use the slowpoke rule. The vector points to the side that finishes last.
The slowpoke rule. I like it. Let's apply that.
Yeah.
Left bundle branch block, LBBB. The highway to the left ventricle is out.
Okay, so the signal goes down the right highway perfectly fine, The right ventricle fires fast, zoom, but the left ventricle is sitting there waiting.
It didn't get the memo.
Not yet. The signal has to crawl from the right side through the septum into the left muscle. This takes time. So the right side finishes firing and the left side is still going.
So at the very end of the beat, the only electricity left is on the left side.
Exactly. So the vector swings dramatically to the left. You get intense left axis deviation, like medic of 50 degrees, A&D, a wide QRS.
The right bundle branch block.
RBBB. Same story, reversed. The left fires fast, its highway is clear. The right lags behind because its highway is closed.
That's the slowpoke.
It's the slowpoke. So the vector swings hard to the right at the end of the beat because the right ventricle is the last one standing.
So wide QRS plus right axis deviation equals right bundle branch block. Wide QRS plus left axis deviation equals left bundle branch block.
You've got it. It's all about who finishes last. The vector points to the slowpoke.
That is a great rule of thumb. The vector points to the slowpoke.
It works for hypertrophy, too. More muscle takes longer to fire. It works for blocks. It's a universal principle.
Moving on to section 6, voltage. Sometimes the squiggles are too tall. Sometimes they're tiny.
Too tall is easy. We just talked about it. Hypertrophy.
More muscle.
More muscle cells equals more voltage. If the sum of the voltages in leads 1, 2, and 3 is greater than 4 millivolts, you've got high voltage, usually big heart.
What about low voltage? This is interesting. The signal dampeners.
This is diagnostic gold. Suppose you see a tiny QRS complex in all leads. The battery is weak. Why?
Could be the battery itself is broken.
Yes, that's one possibility. If a patient has had multiple heart attacks or infarctions, a lot of muscle has died and turned into scar tissue. Scar tissue doesn't generate electricity. Less muscle, less voltage. That's a cardiomyopathy.
But what if the muscle is fine, but the signal is just muffled?
Think about what surrounds the heart. If you have fluid in the pericardium, the sac around the heart called pericardial effusion,
Fluid?
that fluid acts as a short circuit.
Like dropping a toaster in a bathtub.
A little less dramatic, but yes, that's the principle. The electricity conducts through the fluid around the heart instead of reaching the skin where electrodes are. The signal is shorted out before it gets to the surface.
So tiny squiggles can mean fluid around the heart?
Or air, pulmonary emphysema. If the lungs are overinflated with air, they wrap around the heart. Air is a terrible conductor. It's an insulator.
So it blocks the signal.
It blocks the signal from reaching the chest wall.
So if a patient has emphysema, their ECG will look quiet.
Very quiet. Low voltage.
This is amazing. Just by the height of the line, you can tell if someone has fluid, air, or a weak heart.
It's detective work. You are looking for clues in the voltage.
All right, now we get to the most critical section. Section 7. The text calls this the most important part of the chapter. The current of injury. This is how we detect a heart attack in progress.
This is the Save a Life section. To understand this, we have to understand what injury does to a cell electrically.
Okay, unpack it.
When a part of the heart muscle is injured, say it's not getting enough oxygen, which is ischemia, it loses its ability to maintain its battery charge.
It can't repolarize properly.
Exactly. It remains depolarized all the time. It stays negative.
It stays negative, even when it should be resting.
Yes. Even when the heart is supposed to be resting, which is polarized or positive, that injured patch stays negative.
So imagine the heart is a sphere. Most of it resets to positive between beats. But there is this one spot, the injured spot, that stays negative.
Exactly. Now remember our rule. Current flows from negative to positive.
Wait, if there's a voltage difference, current must flow.
And it does. This is the provocative thought we hinted at. In a patient with an acute heart injury, current flows between heartbeats. During the TP interval, the resting phase, there is a current of injury flowing from the injured area to the healthy area.
The heart never stops flowing. That is intense.
Never. But here's the problem for the ECG machine. The machine doesn't know where zero is. It deals with relative voltages. It uses AC coupling. It can't tell that there is a constant DC current flowing during the resting phase.
So it just recenters itself.
It masks it. It shifts the entire graph so that the resting phase, the TP interval, looks like it's at zero. But it's not at zero. It's actually depressed because current is flowing.
So how do we see it? How do we find the truth?
We need a reference point. A moment in time where we know there is no current.
Is there such a moment?
There is only one. The J point.
The J point.
Yeah.
Sounds like a spy thriller location.
It stands for junction. It is the exact split second when the QRS complex ends and the ST segment begins.
Why is this point special?
Because at that exact moment, the entire ventricle has just fired. Every single cell, healthy or injured, is depolarized. Everything is negative.
So if everything is negative, there is no difference.
Exactly. If everyone is shouting, no one stands out. There is no voltage difference, no current flow. The J point is true zero.
So we use the J point as the anchor.
Yes. We
Yeah.
draw a line horizontally from the J point. That is our zero line. Then we look at the rest of the graph. Specifically, we look at the segment between beats.
The TP segment.
Right. Because of the injury current, the TP segment is actually shifted down. But remember, the machine shifted everything UP to fix that.
Oh, I see where this is going. If the machine shifts the bottom up, then the J point, which was 0, gets shifted up too.
Bingo. The J point and the ST segment appear elevated above the baseline. This is what doctors call ST elevation.
It's an optical illusion of the machine. The resting line is actually low, but the machine drags it up to the middle, which makes the 0 line, the J point, look high.
Exactly. That is the mechanism of ST elevation. So practically speaking, if the ST segment is elevated above the baseline, we call it a STEMI, an ST elevation myocardial infarction,
Heart attack.
a heart attack in progress. And we can map this with vectors too.
Okay, so what's the vector rule here?
We can. The text gives us a rule. The vector of the current of injury points from the normal tissue toward the injured tissue.
Wait, let's trace this carefully.
Yeah.
Healthy tissue is positive during rest. Injured is negative.
Right.
Current flows negative to positive. So
Actually-
current flows from the injured area to the healthy area. So the arrow points to the healthy area.
Right. So physically, during the rest period, the vector points away from the injury. This causes the baseline to drop in the leads facing the injury.
But the machine shifts at UP.
Exactly. So on the printed paper, the ST vector, the shift you see, points toward the injury.
That is the practical rule. The ST elevation points at the crime scene.
Yes. If lead V3, which sits on the front of the chest, shows massive ST elevation, the injury is right there. Anterior wall infarction.
Anterior wall. That's the Widowmaker territory, isn't it? The left anterior descending artery.
Often, yes. The vector of injury is pointing strongly toward the chest wall. The V3 camera sees the train coming.
What about a posterior wall infarction? The back of the heart?
The injury is in the back, so the ST vector points toward the back, toward the spine.
But we don't put leads on the back usually.
No, we only have leads on the front. So if the vector is pointing out the back,
It's pointing away from the front. The train is leaving.
so the front leads show ST depression.
Fascinating. So ST elevation in the front means front attack. ST depression in the front could mean a back attack.
Exactly. It's like seeing the taillights of the train leaving. You know it went that way. It's a mirror image.
Now, this injury current doesn't last forever.
Mm.
Section 8 talks about the recovery.
No, it's a temporary phase. Figure 1221 in the text shows the timeline perfectly. Day 1, acute phase, huge current of injury, massive ST elevation. The muscle is screaming.
Yeah.
1 week later, the injury potential diminishes. The tissue is either healing, getting some blood flow back, or it's dying.
And 3 weeks later,
The current of injury is gone. It's resolved one way or the other.
and if it dies, if the tissue dies,
If the muscle dies, it becomes electrically silent. It's an electrical hole in the heart. And this leaves a permanent scar on the ECG. This is the pathological Q wave.
the Q wave. We mentioned a tiny normal Q wave earlier from the septum, but this is different.
Right, a normal Q is tiny. A scar Q is deep and wide. Here is the physics. Imagine the heart vector is usually a summation of the back wall pushing electricity forward and the front wall pushing electricity backward. They balance each other out somewhat.
Like a tug of war again.
Exactly. Now, kill the front wall, it generates zero electricity, it drops the rope.
So the back wall wins instantly. There's no opposition.
The balance is gone. The back wall is still firing, pushing backward, but there is no front wall pushing forward. The net vector swings violently backward, away from the dead spot.
So the chest leads, the cameras on the front, record a massive negative deflection, a deep downward dive.
That is the Q wave. It is the signature of an old heart attack. It tells you something died here.
So let's recap the timeline, because this is critical for you to understand.
Absolutely.
ST elevation, happening out. Current of injury, emergency. Deep Q wave, happened in the past. A scar.
That is the golden rule of ECG timing. If you see ST elevation, you run to the cath lab. If you see a Q wave, you ask about their medical history.
We are in the home stretch here, section 9. We talked about the QRS, the ST segment. Let's finish with the T-wave abnormalities.
The T wave is sensitive. It's the canary in the coal mine. It's the first thing to change when the heart is just a little bit unhappy, mild ischemia. Maybe you're exercising and your arteries are a bit clogged.
The text mentions biphasic or inverted T waves.
Remember we said the normal T wave is positive because repolarization goes backwards from outside to in?
Yes, that was the paradox.
Well, if you have mild ischemia, a shortage of blood, the repolarization period of that muscle shortens. It happens too fast. This disrupts the normal outside to inside sequence. The wave flips direction.
And if the wave flips direction, the vector flips direction.
Exactly. So the T wave flips upside down. You get inverted T waves. If you see that, you think ischemia. The heart is struggling for oxygen, but it's not dead yet.
And what about digitalis? That's a drug, right?
Yes, often used for heart failure. It makes the muscle pump stronger, but it also messes with repolarization speeds. It creates a very specific shape. The biphasic T wave,
What does that look like?
it goes up, then down, like a sine wave. It's a very specific scooped out look. If you see that, you might be dealing with digitalis toxicity, an overdose.
It's incredible how specific these lines are. A squiggly line can tell you if a patient took too many pills.
It really is a language. Once you learn the grammar, you can read the story.
So let's synthesize all of this. We've covered a lot of ground. We started with the heart as a generator. We mapped the hexagon. We watched the vector spin through the QRS. We saw it swing left or right with hypertrophy.
Right.
We saw it get blocked in the bundle branches. And we saw the dramatic signals of injury and death.
It's a complete story of the heart's health, written in voltage.
When you look at an ECG now, what is the first thing you look for? Give the listener a strategy.
I scan it in order. First, I look for the axis. I check lead I and lead 3. If lead I is positive and lead 3 is positive, normal axis.
Easy enough.
If they are pointing away from each other, left axis deviation. If they are reaching toward each other,
Right.
axis deviation, that splits the diagnosis instantly.
And
Then I look for the width. Skinny or wide QRS. Wide means block. The signal is taking the side streets.
the slowpoke rule.
Exactly. Then I look for the current of injury. Is the ST segment elevated? That's the emergency. And finally, I'm looking for those ghosts, the Q waves of the past.
It changes the way you see the human body. It's not just a thumping drum. It's a precision electrical instrument.
Absolutely. And remember that final thought about the current of injury.
Yes, let's leave the listeners with that. It stuck with me.
We think of the heart as beating and resting. Beat, rest. Beat, rest. But in an injured heart, during that rest, there is a silent, invisible current flowing continuously from the wound to the healthy tissue. A battery of injury.
Wow.
The heart effectively never sleeps, especially when it is wounded. It is constantly signaling its distress, even in the silence between beats.
That is profound. And a little haunting. But thanks to vectorial analysis, we can hear that signal and do something about it.
Knowledge is power.
Thanks for diving deep with us today. Next time you see a doctor holding that pink strip of paper, you'll know they aren't just looking at squiggles, they're calculating vectors.
Hopefully.
And we'll see you on the next deep dive. Stay curious.